thank you all for coming back. Thank you. So in this next section of the program, we're going to talk about what it really looks like to see AI in action. And the next session was billed as a panel, and it sort of is, but we thought it would be a better format to have our two speakers have some dedicated time to share their experiences, their use cases, and different lens on AI within their own institutions with you. So they're each going to do that for about 20 minutes each, and then we're going to have the opportunity to ask them some questions. So I'm going to introduce our first speaker, and our first speaker is Dr. Rodolphe Katra, and he's the Global Chief Artificial Intelligence Officer at Medtronic. I got it right this time. And he leads the Enterprise AI Center of Excellence. He has a doctorate in biomedical engineering and an MBA. He's a thought leader, an innovator, and co-inventor on 100 plus patents either granted, published, or pending. Please welcome Rodolphe Katra.
Or music. Is it work? Okay, brilliant. Thank you. I won't go through too many slides. I just wanted to put some context. But first, thanks for coming back. Thanks for the invitation to speak to you about this. And it's, I don't know if it was a setup to go after David and Lou because they already touched on all the important things. I guess I'll just show you things through pictures because I'm a visual learner. But the slides are not up. So can we get the slides up? It's coming. We need AI for that. Brilliant. Okay. So we'll talk a little bit about AI in action and maybe focus in on the responsible and ethical portions of it. So, all right. You heard AI is not new. It's been around for over 75, 80 years, started after World War II or a little bit during World War II. But the modern era of AI is described in multiple applications that you see visually in this schematic. It's everything from what you encounter and interact with on your phones. It sorts your pictures, it transcribes your text. Somebody listens to your speech, whether sometimes you want it or not, and it transcribes it for you. So there's a lot of computer vision, there's a lot of natural language processing, there's a lot of text-to-speech and transcription, as we heard earlier, a lot of robotics. But when we start talking about healthcare, the biggest applications we typically reference is what you see on the top right side, which is machine learning and deep learning, as David described earlier, and then more recently, generative AI came to the mix. The reason I put this up there, and I like talking about it, because in healthcare, the biggest applications we talk about are typically in the machine learning, deep learning application. And more importantly, generative AI is not currently regulated, so there is no medical product you use in the hospital that is FDA cleared and CE marked in any way. So most of the medical applications that the physicians use for patient care are FDA cleared and CE marked. And that's an important distinction when we talk about responsible use. But when we talk about the application of AI, we also need to consider the context. I don't know what I'm doing wrong here. So, all right, the context of how these models are applied. All the applications that are machine learning and deep learning that's applied now in healthcare are locked, which means the moment the algorithm is developed and validated and deployed in healthcare, it does not adapt. It does not, from every encounter it deals with the patient, it doesn't modify its performance. And this was meant to avoid performance drift and picking up bad habits that are unintended for those use cases. So unlike generative AI or adaptive systems where like your shopping profile at Amazon or Netflix, that every encounter you have with the system, it learns what you like and it starts recommending things along the same genres, this is different. This locked AI does not care who you are and what you got, it will act the same way over and over. But I would argue this is the now, And the true power of AI is being able to adapt. So we've taken a very powerful system, we've shackled it to a performance that we currently can live with. But you can imagine in a future where this technology could be adaptive and it could become so personalized, but it needs to be safe and effective and responsible. So at Medtronic, we have published our AI Compass, which is our ethics and our principles that we use to work on AI, and it has to adhere to these 7 principles. This is what everybody who works on AI solutions within Medtronic kind of lives by. And it has to have a beneficial value, either to the patient's outcome, to a physician's delivery of care, or to the health system at large. Ideally, solutions could do all 3, but they don't have to. A meaningful improvement on any one of these pillars is good enough to bring products to market, improving patient outcome, physician engagements, and healthcare system costs. So when you think about how AI is applied in healthcare currently, you can think about some of the applications we heard a little bit earlier about. It could be a healthcare process where there are clinical decision support systems. It helps you with managing routine medical tasks. It can help with workflow and so on. But the other application is more deriving clinical insights. I didn't do anything, I promise. Is working on clinical insights, which is helping physicians and helping the healthcare system derive insight we previously were not able to do. And in that space, you could think of its applications in smart procedures. So think about your colonoscopy, think about your interventional procedure or your surgery, or it could be applied to implantable or wearable the medical devices. Think about your diabetes pump, think about implanted cardiac device, and so on. Both of those applications are different, but they all based on implementations of AI based on how healthcare wants it to be done. And I'm kind of annoyed that I don't have enough time, but I will put a teaser in there to tell you that in the future, we believe healthcare is going to be changing dramatically with AI, as you heard a little bit earlier, but it's going to usher a paradigm of personalized, predictive, and preventative care. And those 3 make big difference. Personalized, we talked about adapting to a patient's needs. We currently don't have the clinical or regulatory language to these kinds of systems. We're talking about an N of 1 type of trial. Like, I don't care if an algorithm, if I had a heart disease, for an example, I don't care if my algorithm is good enough for the rest of the world. I want it to be the best it can be for me. So whether it works in a ethnicity, in another country of a different gender, that's great. But if it's not what I needed, do I care? So we're going to shift the healthcare from a paradigm where we want it to work for everybody to be hyper-personalized and adapt to my genetics, my lifestyle, my medication adherence, my specifics of a disease. And how do we build clinical trials for that? We're talking about N of 1 type clinical trials. We're talking also about regulatory processes that don't exist to regulate algorithms meant for an individual versus a cohort or a group. But that's the future, and we want to shift towards prediction versus wait for somebody to come into hospital, as you heard earlier from David. We also want to move to prevention instead of reactive care. But you can't spell AI without data. Okay, I'm not very good at it. So to me, I hear a lot about data. We talked a lot about data, but let's talk about responsible AI and the use of data responsibly. Data to me is like Legos, like a big jumble pile of Legos. And then if your goal is to build a house, which is on the right side, not all the blocks are necessary. You may be missing certain blocks. You may need to go through a process of rigorous data engineering before you're able to distill what you need to do and build that story on the right. So it's important to say when you have data that you use it appropriately for AI, but not all data is created equally and not all data is useful, and that's important. So when we think about it at Medtronic, or at least the world as they address this, we think about the V's and the P's. So there are 3 V's. We need enough data, so you need enough volume of it. It needs to be accurate, so you need a good veracity of that data. And then you have the variety, so you need it to be representative of the disease condition you're trying to address. You also think about the P's, because there's patient data, that's physiologic data that comes from the patient and the disease they're experiencing. You need product data, so whether it's a device or a surgical procedure or a CT or an MRI, that's information you get from the medical equipment. And then you need the practitioner's data. That's the medical know-how they have and that they distill as they deal and help these patients. So in various combinations, you will need some of the P's to put together that story in that house. But because we're talking about responsible AI, I want to bring up this beautiful example, which I think is very thought-provoking. Anybody know what that is? This was a study published by Andrew Wald, a statistician from World War II, a Naval Academy statistician. They were getting these bombers from World War II come back with all these bullet holes in them. The Navy saw these. They were losing a lot of planes. They're like, oh my gosh, look at all the holes. These are the planes that came back. Let's reinforce these areas, and then maybe more of our bombers survive. And that's the program that started by the Navy to reinforce their bombers. And it took a very clever statistician to say, look, wait a minute. These are the bombers that made it back. So maybe the key is in the data we don't have, which is planes that have been shot in the areas that are black. Maybe those are the ones that are falling to sea. So take that analogy to healthcare. If we only deal with healthcare data that exists in the EMR, data that we see in front of us, you are missing the elements of data that may be super important but never made it to the hospital, either for socioeconomic reasons, for insurance coverage, for referral pathway, cultural, gender. So think of all the barriers and the obstacles for people receiving care, and that's the data that's missing from our arsenal to be able to build powerful solutions. But I promise to make it real, so I'm going to give a couple of examples on products. And I'm Medtronic, so I will only, there are great solutions by other companies as well. I'll just talk about the ones we have. And it's meant to be illustrative for no other purpose. This is an insertable cardiac monitor. So if you have atrial fibrillation, stroke, or syncope, or transient loss of consciousness that happens infrequently, a physician may want to diagnose a patient. They do a test. They don't see anything wrong, but they know that patient is having these conditions. So they put this small, tiny, insertable cardiac monitor under the skin. It's meant to collect and monitor your heart for 5 years, 24/7, beat by beat. The goal is to, when in doubt, when you suspect there's an arrhythmia, capture it, send it to the physician so the physician and clinician can look at it and deliver care. That device collects ECGs from the heart, whether it's an arrhythmia or not, and sends it through either a phone app or a bedside monitor to a monitoring station. The key here is it's designed for high sensitivity and relatively low specificity, because the goal is you do not want to miss an episode that's critical, even if you tend to oversend information to the physician and have them say, no, that's not important, I don't care about that. But you don't want the opposite. You don't want things happening and the device not triggering on those solutions. While this in theory is great, the problem is that we heard from a lot of our physicians that there's way too much data, way too much information coming in. Manage a clinic of 200, 1,000 patients with a lot of this information. So we took about 1.5 million ECG that's adjudicated and trained and labeled by expert physicians, and we trained this AI to recognize patterns of false episodes, which means if there's an episode that was flagged by the device that's called an AF or called a pause, and it's false, suppress that. So we maintained relative sensitivity at near 100%, but we were able to drop the false episode count dramatically. And what that translated to about 400 hours of clinic time saved in a very typical clinic that has 200 patients. Most clinics have over 1,000. So now we're talking about 10 weeks of work that's saved by improving the specificity down to about 91%, while maintaining sensitivity. So this has an impact of directing precious healthcare resources to the patients that need them, and you're not alerting and having patients come in when they don't need to. So it translates to a win to the patient, a win to the healthcare system, but also lowers cost of care delivery. That's one example. The other one is in the space of endoscopy, which hopefully all of you guys are getting your colorectal screening done. This is a device that Medtronic introduced. It's essentially an an aid to an endoscopist that has a real-time AI using computer vision that looks at the videos and helps detect polyps. Polyps that could be missed, polyps that could be benign. So with this technology, we've seen that it reduces the miss rate of polyps, which currently is around 50%. So a physician that does 20 cases a day, they're tired, or some things are not very obvious, some polyps are missed. This solution reduces the adenoma miss rate by over 50%, which translates to better colorectal cancer screening solution. The third example is in the surgical space. If you have a spinal deformation or a scoliosis or degenerative spinal disease, a lot of patients require rods and screws to help align and support their spine. Right now, the methodology is you come in, you'd get a CT, the physician, just like a machine shop, bends titanium rods to the shape they think you need, and then that's the surgery you get from these rods. And that's been super effective. The issue is that's not totally personalized, and that's done in the surgical theater. Imagine if you can get a screening of that patient with a CT, and you create a pre-procedure surgical plan and the right alignment that the physician wants to use for that given patient. Those rods can then be bent custom to that particular patient. They are sent to the hospital. The physician applies the right rods for the right patient that are formulated for their unique spinal configuration. And then you track post-operatively the success of that solution. And it serves as a virtuous cycle where your pre-op planning is matched by intraoperative care and post-operative follow-up, and you rinse and repeat for improvement of patient outcome. So this shortened procedure time, improved patient outcome, and personalized the rods and screws used for these patients. So I'm going to leave with this, and since we are talking about responsible AI, the barriers are abound. Even if you have a magic wand and you solve all of these problems, there's still an adoption and awareness and an educational piece that needs to be maintained. There are issues with access, there are issues with reimbursement, there are issues with regulatory and clinical considerations. There are issues that still need to be solved. But rest assured, as we've done with, as the healthcare industry has done over the last 5-6 decades, we chip at those a little bit at a time, and we provide solutions to market that healthcare can react to and respond to. But even if you do it, there's also the human nature, and we talked a little bit earlier about change management. You're going to have some physicians that are on the adoption curve that would say never, no way, no how. And you'll have some that are pioneers and leaders who are ready to embrace technology. And that's not unique to AI. That adoption cycle is a classical adoption of technology, regardless of what it is. Some of us still don't drive a Tesla. Some of us still don't have a smartphone. So some of us still don't use GPT, which you heard earlier. You probably should experiment with that at home. So these are when AI meets the real world, some of the considerations and applications for responsible AI. And I'll end it here. Thank you.
Thank you, Lou. Our next speaker is Sarah Harper. She is the manager of AI analytics and automation at Mayo Clinic Health System, and she oversees the actual implementation of AI, ground level. So what insight that she'll be able to give us. Sarah is really, really interesting. She has an MBA from St. Thomas, but I'll also highlight that she comes to her role at Mayo as an educator. So she has a master's in Hispanic literature. She was a K-12 teacher and coach. She taught healthcare administration in the Mayo Clinic College of Medicine and Science at St. Thomas. And I think that you'll hear through her comments that through that educational lens, really is an expert at figuring out what it takes to implement. She also has an incredible sense of humor, personally and professionally. Her posts about coming to Convene have increased some awareness because they were so funny and so clever and so engaging. So thank you so much for supporting Convene by being a guest, but also by just promoting everything on LinkedIn with your wonderful humor. So Sarah Harper.
Hi, everybody. It's great to be here. I've been wearing glasses since I was in 7th grade, so I'm going to be using my notes here, and I might be squinting a little bit, but I appreciate your understanding. The first part of my talk, I'm going to be relying on my notes here, but then I'm going to take a risk and come out from outside the podium, not trip on this cord here, and kind of wing it about some of our practical examples in MCHS. So without further ado, I'm Sarah Harper. I'm a manager of AI, analytics, and automation at Mayo Clinic Health System, and I'll explain what that means and how it's different than Mayo Clinic, but also the same throughout my talk. I'm excited to dive into our recipe for responsible AI in healthcare with you today. So why are we here? Why are you all here? Hopefully it's because you wanted to learn about responsible AI and why we should care about it. We care because there's limitless opportunity, as you've heard, for improvement in healthcare delivery, both for patients and for care providers. It's likely that most everybody in this room knows that the United States has almost double per person healthcare spend and worse outcomes compared to other wealthier nations. And also, on top of that, kind of compounding the problem, Becker's Hospital Review predicts that by 2028, we're going to have a shortage of more than 100,000 healthcare workers. So we have a problem to solve. We have a sense of urgency. And plain and simple, we need help. We as humans. As healthcare leaders, we have a responsibility to assess all the available tools and technologies at our disposal that can help us ensure that patients have better access to affordable quality care. So to put it simply, and also to tip my hat to my brilliant friend and podcast co-host, Elliot Wilson, machines make healthcare more human. So we're going to talk about how that's possible. So where are we headed in my portion of the talk today? I'm going to share our secret sauce with you, at least in the Mayo Clinic Health System, our recipe for responsible AI. I'll talk a little bit about our approach to implementation and evaluation of AI models in practice in MCHS. I'll give you some practical examples of how we've done that. And then, of course, we're going to have some exciting discussion on stage with Rodolphe and Archelle and myself. So I was a history major, fun fact. So I can't begin any talk without just looking back, taking a glance back at our heritage and seeing what we can learn from it, or what helpful reminders we have as we chart our path forward. So one of Mayo Clinic's 2 founding brothers is Dr. Will Mayo, and he reminds us that, at least at Mayo Clinic, we have never been allowed to lose sight of the fact that the main purpose of the clinic is the care of the sick. That is what is informing absolutely everything we do in every era that we are practicing medicine in. And I love this quote because it reminds me of our primary value at Mayo Clinic, which is the needs of the patient come first. And whether I'm taking care of a patient or I'm shepherding a model into practice, it needs to inform absolutely everything that I and my teams do. So fast forward 170 years after Dr. Will and his brother Charlie founded Mayo Clinic, we still hold true to our primary value, and as such, we have a responsibility in healthcare to use technologies responsibly. Our recipe for, I think I need to click so you can actually see my recipe. Our recipe for responsible AI implementation in Mayo Clinic Health System requires 4 key ingredients: insight into where the best opportunities are, discipline in how we go after those opportunities safely and responsibly. It requires teamwork, or another word you could sub in collaboration, from a lot of humans, and it requires humans. Responsible AI requires humans at the end of the day. So we're going to talk about what all that means. But before I dive into that, I just wanted to give you a brief overview of Mayo Clinic Health System for those of you in the room that aren't familiar with our organization, just kind of set the stage for where my team and I do our work. So Mayo Clinic Health System provides category of 1 care close to home. We have 45 multi-specialty clinics, 16 hospitals, 2 mobile health clinics, and a primary care on-demand practice, serving over 39 communities in rural settings across Minnesota and Wisconsin. Our team is comprised of over 1,000 physicians, nearly 13,000 allied health staff. We serve 1.6 million patients per year and have nearly 28,000 surgical cases per year. So that just gives you kind of a sense of who we are in MCHS. We are part of the larger Mayo Clinic enterprise organization, but we have a unique population that we're serving, a slightly different business model, and that definitely informs our work. Just to give you a sense of our geography, we have the 4 hub hospitals that are located across southern Minnesota and western Wisconsin. Also very proud to report that Rochester and Mankato hospitals are among America's 50 best hospitals according to Health Grades. And our hospital in Eau Claire was named among the 100 best. Eau Claire and Mankato also have been named the best regional hospitals by US World News and World Report. So really strong category of 1 care. Now that you know a little bit more about Mayo Clinic Health System, I'd like to introduce you to the people or the team applying AI responsibly in community medicine. These are the brilliant individuals that I have the privilege of working with every day. There's a lot of hype, as you all know, surrounding AI, and I just wanted to take a moment to ground us in the humans behind the work. If your idea, like mine, of a thrilling Friday night is reading the latest updates from the Department of Labor Statistics with a glass of Pinot by the fire, then you would know that women currently make up only a quarter of the STEM workforce. For this reason, I'm really proud to be part of a team that's over 50% female, and the leadership is 67% female, and we are actually doing the work shaping the future of AI in community rural medicine. So very excited to show you my team there, and to kind of continue on a little bit about what we call the A3 team in Mayo Clinic Health System, AI Analytics Automation, A3. Our vision is to leverage the power of data to ensure that community-based healthcare thrives. Our mission is to power clinical practice innovation, so it's a little bit different than the research discovery space. Clinical practice innovation and revolutionize community healthcare through our work, through AI, automation, analytics. And in keeping with our primary value, we need to put the needs of the patient first in everything that we do. Okay, for a fun fact, my slide didn't advance there. Okay, super. Let's get back to the recipe, okay? The 4 key ingredients. We need insight, discipline, teamwork, and humans, okay? So what does that actually mean in practice, okay? So responsible AI requires insight into where the best opportunities lie, okay? We heard a little bit about this in Lou's talk with Archelle earlier. Healthcare margins are notoriously slim, and as such, opportunity costs of putting our eggs in the wrong basket or in too many baskets are extremely high. So in our experience in Mayo Clinic Health System, using this framework, the innovation sweet spot, we find that the best opportunity for innovation through artificial intelligence in medicine is always where we have the intersection of desirability, feasibility, viability, and scalability. So we've modified, we can't take credit for this, I actually got a link which is pretty invisible down here on the bottom, but if you search Kimberly Orton on Medium, this is her work, I want to give her credit for that. We've modified it slightly by adding that sort of sub circle within the Venn diagram to represent scalability. So let's talk about what each of these mean from a practical standpoint. What does desirability mean when we talk about health AI? We need a problem to be solved, right? Duh, I mean, everybody knows that. But we really truly need to clearly articulate the problem, and we need it to align with our strategy. There has to be strategic alignment. There's no shortage of problems in healthcare, but we all need to be rowing in the same direction, right? And then we need to have change readiness, not just among that really exciting innovator who happens to be a nurse leader or a physician leader, but who is that solution going to impact at the end of the day? Is it going to impact patients? Is it going to impact nurses? Is it going to impact PTs? Well, they need to also be really excited about solving this problem, or guess what? It's not really going to work. You're just going to have a very expensive toy that sits on the shelf. Feasibility. We need accessible, reliable data. We've talked about that a lot. You've heard that in the previous, from the previous speakers. We also need evidence-based practice. We need to know what is the best course of action, best standard of care, grounded in foundational evidence to know how to deploy these models in healthcare. And we also need relatively low risk. So we'll talk about that a little bit as well. Lastly, the viability circle. We need operational capacity. Somebody has to use these tools, right? And this is kind of the automation paradox that we hear about, where everybody's worried that AI is going to replace them, yet we really need AI to fill up some of these jobs that we don't have humans for, right, to take over these tasks. And when it comes to having successful AI implementation in healthcare, my job really is to say, okay, great, that's a wonderful idea for a model. Who's going to do what with it again? And please tell me that you're not planning on hiring 12 nurses to use this new tool, right? How can we take our existing team, our existing knowledge, blow up the workflow, and reimagine care delivery where we have humans partnering with technology? So we need operational capacity. We need streamlined, scalable workflows that are repeatable and standardized and truly scalable across a geographic region. And yes, a geographic region. That's it. Stop talking, Sarah. The last bit about viability is, we've heard this too from our previous speakers, is we need a commitment to monitoring. We can't just measure value at one single point in time and say, okay, the model's accurate, we're going to deploy it. We did a pilot. Wow, we saw a 150% increase in lung cancer screenings after we implemented the solution. Go us! And then we just move on, right? We need an operational structure that exists and a technological one to continuously monitor not just the model's performance, but the workflow's performance, and is that solution continuing to add value, or is it 2 years too late and we need to pivot and do something else? Okay, so responsible AI also requires discipline. This is a very simplified version of how our team deploys a model into clinical practice. We need a structured scientific approach to development, validation, deployment, and monitoring. Whether you decide to build, buy, or partner, or a mixture of all of those things when it comes to AI model development, I can assure you that the easiest part of the whole process is developing the model. And it's also the most fun, right? But people typically forget about the steps before and after. This visual, as I mentioned, is a concise overview of kind of our development and deployment pipeline. It includes little asterisks wherever we have sort of standard regulatory checkpoints where we need to make sure we're checking with our institutional review board or a software as a medical device board, as well as we have an internal AI translation advisory board. So we have many governing bodies that all kind of have oversight in terms of the type of solution we're developing and who it's for. This I'll touch very briefly on. It requires teamwork. Responsible AI requires teamwork and collaboration. This is another very simplified visual of all the individuals that I work with every day to make sure a project is successful, okay? And at the center of it is patients. But we need, I need to scroll down. We need clinicians and patients to help us identify the pain points, right? What are the problems that need to be solved? We need operational leaders that can help support change and optimize processes, right? Because we don't want to automate waste into a broken system. We need solution developers, right? We need data engineers that can develop and validate our models. We need regulatory advisors, both internal to our organization, that know our organization and our knowledge and our unique capabilities, as well as external regulators that can check us, right? So we need both of those. We need implementation scientists. We need people whose job it is to work with the clinical practice and get the solution into practice successfully and drive that adoption. And then we also need folks that are trained as researchers or simple analysts in quality improvement frameworks that can monitor the impact of these solutions in practice, not just at that single point in time, but ongoing, as I mentioned before. So this is the last really boring kind of graphic-y slide, but responsible AI does require humans, okay, in the loop. Everything we develop at Mayo Clinic Health System is a supplement to human decision-making, right? It is a critical tool in healthcare that leaders can apply within their organizations to return joy and human centricity to medicine. Foundational evidence at the top left there, that is what informs our model development. And then clinicians will use the model and its output as one tool in their clinical decision-making toolkit. And then those decisions, ideally, are going to go back into the model and make it better, but they're also going to go back into our foundational evidence. Okay, this is the fun part where I get to come out and be a little bit more human with you. So what can responsible AI do for our patients and care teams? Okay, let's talk about some practical examples. I think I need a clicker. Great. I broke them down into slightly different categories than Rodolphe, but starting with clinical and operational, because this is really how we approach our work at Mayo Clinic Health System, is what are the problems we're trying to solve in care delivery, and then also from an operational standpoint, how can AI help us be more efficient and data-driven as we make strategic decisions about the future. So the way I'm going to frame up each of these examples is just talk about the problem that we're trying to solve and briefly, summarize how we're solving it. I want to just say as a general disclaimer, some of these solutions are deployed to production, others are in validation, some are in development, so they're all at different stages, and I'm happy to take questions if you have some. So one problem we have is that patients come in for an imaging visit, and the radiologist may detect that they have an incidental abdominal aortic aneurysm, or AAA. But if the ordering provider wasn't necessarily looking for that in their imaging study, they may not search for that particular term or code it properly based on the radiologist's note. So we're using natural language processing to review those radiology notes for keywords, but also the size of the aneurysm, and then properly code the chart and automate a notification to the correct specialty to follow up with the patient that, hey, you didn't actually come in for this need, but we did find something concerning and we'd like to talk to you about it. So using natural language processing to detect incidental findings, not just AAA, but we're also using this for lung nodules and other use cases. This is a project that I'm particularly fond of because my favorite part of my job is I get to supervise 2 AI interns that are undergraduate computer science students at University of Wisconsin-Eau Claire. And they each have an AI project that they shepherd in partnership with a physician scientist at Mayo Clinic Health System and a computer science faculty member at UWEC. So this project was one that our interns came up with to help save time and increase health equity by helping provide rapid access to evidence-based, customizable, or patient-friendly patient education right within a family medicine workflow. So at a giant organization like Mayo Clinic, where we have lots of patient education available, most of those resources actually go to neurosurgery and cardiovascular and cancer, right? And primary care tends to be like, wait, what about us, right? We see a lot of diagnoses as well, and we don't have anything to give our patients. So this is leveraging a web scraping technology, taking publicly available data from mayoclinic.org, running it through a large language model to help end users, and then delivering it to a simple UI to help end users, which are family medicine providers, search for the patient education they need and customize it to the patient's needs. Low vision issues, we can increase the font size. Do they have low literacy or low health literacy? We can have a simplified text option. And they did develop a feature to be able to translate this to any language. Where we're stuck on that, being able to release that feature is we can't validate it, to be able to say this is clinically accurate in another language. We can't validate it yet, I should say. We're in the process of working on that. Another example of one of our interns' projects that's in the validation stage right now is helping our gastroenterologists save time and reduce clinical variance in practice, because variance in practice leads to variance in patient outcomes, through intelligent colonoscopy follow-up recommendations. So we're querying a couple of different databases at Mayo Clinic where we have colonoscopy reports and pathology reports, running those through a large language model and comparing those results to evidence-based practice guidelines, and then surfacing a recommendation to the gastroenterologist about when we should have this patient back for their next screening. And again, this is not making the decision for the clinician. It's one other tool in the toolkit. They can still use their clinical intuition and expertise. They can consult the literature. They can consult their colleagues next to them before making a decision. Another example is saving time for our nurses when we are looking, and also helping to ensure we get patients to the right level of care. So our hospital at home program is called Advanced Care at Home, and patients were spending up to 30 minutes nurses were spending up to 30 minutes per patient reviewing the chart for certain criteria to say, is this patient a good candidate for our ACH program? And by developing our ACH model, we're able to quickly risk stratify those patients for the ones that would be really good candidates and maybe the ones that are so-so and ones that we definitely wouldn't want to consider. So it just takes them running this report in the morning to be able to see who they should go around with and check in and see if ACH is a good option for them. I'm going to share 3 operational use cases, and then I think, how am I doing on time? I haven't seen, oh, sweet, okay, thanks. So in the Northwest Wisconsin market, this is a great example of how we can't control the external forces, right, in healthcare. We had 2 of our competitors close within a month last year. And our ER in Eau Claire is overwhelmed with demand. And we knew, our clinical practice leaders knew right away that they needed to use every tool at their disposal, working with our facilities team, working with our nursing leadership, and working with the A3 team to develop solutions. So we've been working on this model development for a year. So it does take quite a bit of time. It's currently in validation stage, and it's going to be ready to be deployed next quarter. But it essentially helps identify when the patient presents in the ER if they would be a good candidate for safe care at one of our critical access sites that's nearby. So rather than admitting them to our hub hospital site, which has the capabilities to care for patients with really acute needs, if we can safely care for your problem at one of our critical access sites, we're going to let you know that and help you get there before the doctor signs the admission order to the Eau Claire Hospital. So really helping to ease capacity strains in a busy ER, but also making great use of underutilized critical access resources. This is one of my favorite slides because it just goes into, it shows the work that goes into the Legos. It's building the Legos, okay? What it takes to comb through the data and sort the data and clean the data and structure it. So what we're facing here in the health system is we have a lot of patients who are medically ready for discharge, but we can't get them a ride home. But we tend to know, in speaking with our social work teams, our discharge planning teams, nursing, that there are some key indicators that would suggest, okay, this patient's likely going to need a ride in 2 days. And it happens to be based on flow sheet documentation and nursing note documentation. So what are the factors that are going to kind of tip us off that maybe we should start planning with some of our transportation partners early? So this is some initial analysis heat mapping that one of our knowledge architects completed in order to inform model development for future workflows. And this is one last example of how we can integrate predictive analytics with different types of AI solutions. So this is an application, it's a homegrown application called OR Insights that we developed for Mayo Clinic Health System to bring all of our data and analytics into one platform. We want to improve patient access to life-saving surgeries through intelligent management. What we need is to be able to present our leaders with the best possible data so that they can make good staffing decisions. So this data includes case data related to staff, ORs, instrument processing, robotics machines, you name it, all in one place. And my favorite part about it is it has a co-pilot integration. So if I'm busy and I'm headed to my leadership meeting, I can just say, what are the greatest opportunities to improve room utilization in the next 2 weeks? And here it's suggesting to me OR room 2 has a high number of unscheduled minutes available and significant scheduled wheels in to wheel out duration. Okay, so it gives me some insight in just a few moments about how I can optimize my practice. So let's review very quickly. Responsible AI in healthcare requires insight, discipline, teamwork, and humans. And as a history major, I cannot end any talk without a quote from one of our founding sisters. This is Sister Generose Gervais. She was administrator of St. Mary's Hospital, which is now part of Mayo Clinic Hospital in Rochester. We must not be content only to see things as they are. We must have the vision, faith, and hope to see what things can and must become. I love Sister Generose because she was an entrepreneur at heart. So I thank you for your time and your attention, and I look forward to your questions.
So I'm going to ask each of you a few questions, and they're going to be different since the scope of your roles is so different. So don't feel obligated, like we won't have both of you answer all the questions. And I'm going to start that, and then we'll open it up to the audience. And Rodolphe, I'm going to start with you. So you mentioned earlier that there is no generative AI clinical tool that's FDA approved, and who knows when there will be the resources to approve those sorts of models. So I'm wondering, in the US and as a global company, of course, how are you navigating that, and how are you moving your products forward in the absence of a regulatory process?
So we at Medtronic currently do not develop generative-based tools for our healthcare systems. We only confine our work to date to MLDL, machine learning, deep learning-based solutions where we can do clinical evidence and validate, meet with the FDA to demonstrate through clinical trials. Those are deployed in a locked fashion, as I described. We partner with companies that work on generative AI, but remember, generative AI is used for workflow management, like automation, like you heard from Sarah, but it's not in and by itself a tool that diagnoses, manages, treats, the patient directly. So that's an adjunct tool to healthcare and healthcare delivery. We have some tools that minimize the workflow, but still a human in the loop as a process. So right now, with the absence of medically regulated generative AI or multimodal AI solutions on the market, our focus is on the other areas. Now, my teams are working on things in a basement. I lock the door and I slide some food down every once in a while to work on some of these solutions. But once the field and the healthcare system is ready for these types of solutions, once we've gotten over the hallucination impacts and some of the consistency, then you will see more of these solutions coming out for Healthcare 5.0, which is the personalized healthcare piece.
Okay, thank you. And Sarah, are you using any generative AI tools at Mayo Clinic Health Systems?
Yes, I would say they're limited to administrative scope at this time. Not, as Rodolphe mentioned, they're not integrated into clinical practice. Although we do have IRB studies going on right now where we have generative AI solutions for clinical use cases that are in the validation stage.
Okay. So that's sort of interesting. I mean, for me sitting here, I use ChatGPT, many of us do, and other generative AI tools. And it almost feels like, well, of course it's in healthcare, but it doesn't sound like it is quite yet. So an aha moment for me. Rodolphe, what keeps you up at night as you all are developing even machine learning AI-based tools? Is it bad data, black box models, maybe not so much with machine learning, bias? What keeps you up?
So this will be a shocker as the Chief AI Officer. I don't really care about AI, so so don't tell my boss that.
Say more about that.
So I agree with what was mentioned earlier by David and Lou. To me, AI is math. It's sexy math, but it's math. We've been doing math for 60, 70 years. So if it doesn't meet the bill, if it doesn't fit the purpose, the business application, if it doesn't benefit a patient, support a physician, or advance healthcare, AI is just the buzzword we use for some of these. To me, the application of mathematics, so let's call it here AI in that context of the question, is only as good as the data you have underpinning it. And I illustrated a little bit some of what keeps me up at night, which is the underrepresentation of certain data sets that would be relevant, or drawing the right conclusions from the wrong data sets. So it doesn't happen deliberately. We talk about bias. A lot of it is not maliciously somebody looking to perpetuate biases, but if the data is fundamentally unrepresentative, that's a challenge. And Medtronic operates in over 165 countries. No healthcare system is the same. Reimbursement is not the same. The challenges of different healthcare systems are not the same, and they don't store data the same way. So when we create solutions globally, we have to think about the context of how that data was acquired. And Mayo is a great example. There's a fantastic system in the way they do things. You talk to another hospital, they may not follow the Mayo recipe for patient care. So we have to meet the physicians, the healthcare system, the hospital system where they are, in whatever country they're in, and however they're reimbursed for the services they do. And that is the fundamentals that I try to work on, which is get the right data first, make sure you're comfortable with bias representation, the use cases, the survivor bias, as I mentioned, and then the sexy last mile, the machine learning, deep learning, that's the easy part. That becomes the easier part if you've solved all other issues.
Sarah, it looked like you were going to comment.
Yeah, I have a follow-up about like getting access to the data. I think that can be somewhat of a barrier, and I don't want it to stifle innovation. I think it's also incumbent upon leaders to know where their blind spots are and then make an informed decision going forward. So one example is the colonoscopy follow-up recommendation application I shared. Right now, that recommendation is generated based off of data that we have, right? So when was the last colonoscopy that you had at Mayo Clinic Health System? But if your most recent colonoscopy was at Allina, we don't have that data yet, right? We're building the pipeline to be able to get that through Care Everywhere and other applications. But so are we going to shut down the whole application? Or could it still have some benefit, some value in patient care in reducing a certain amount of clinical variation? So instead, we're just letting the end user know, FYI, right, face up on the page, this is the data that's informing this decision. Okay, now you make a decision based on what you might also find in the chart or when you're doing a complete history with the patient, right? And that's how the two can work together, human and technology.
Yeah. Okay, this is the only tough questions that I'll ask you, and they'll be a little bit different for each of you. But
You can ask all the tough questions you want. I may not answer them. But
Okay, so apologies in advance. But Sarah, you described earlier one use case that struck me, and it was that delays in discharge, very often the correlation was didn't have a ride home. Was not surprised. I mean, having been in healthcare and dealt with that, not surprising. And I just have to ask this question. Like, do you need AI to figure that out? Or could you just ask the question, do you have a ride home? So tell me about how you're rationalizing or why that was a good use of AI when it could be replaced by a simple question, at least to the extent that I understand it.
No, that's such a good question. And it comes down to humans are imperfect. There's a lot of variation in human-driven processes, right? And in our engagement with the clinical practice on this use case, it's been, well, who's doing this today, right? And when are they doing it? And it's surprising to hear that if it's happening, a different team member is doing it in each region at a different time, and maybe it's informed by different data, right? And so what we're trying to do is look for all the inputs that would indicate that this patient needs a ride earlier than maybe a human would even think to ask, and standardize it and get it surfaced in the right place in the workflow a whole lot earlier than we're remembering to do it today, because there's so many demands on our attention as care providers, right? And we're taking it completely off the social worker's plate because that's really not their area of expertise. A CMA can do this job, or a health unit coordinator can do this job if they have a registry of patients who are predicted to need transportation in X number of days, and these are the available modes of transportation, and we can be an air traffic controller. It's an unlicensed skill, right? And you can have a centralized center doing that work, and the social worker and the nurse can actually be doing their expert care at the bedside without having to remember, oh, did I ask about transportation yet, right? Because it's not happening currently.
You know, you opened by saying AI makes healthcare more human, and it is a totally different frame on how we think about AI, but that's a really, maybe a good example of how it can make healthcare more human, because humans just aren't doing it,
Right.
But it's so important. Okay, have you, Rodolphe, ever pulled the plug on an AI initiative?
yeah.
Well, we'd like to
Which
hear
one?
more. Can you share any more about that?
Well, I mean,
And why? I mean, really why?
so I mean, we do and this is not unique to AI, any project has to meet these criteria. We talked about the benefits to patient, physician, and healthcare system. And when we start, the idea may be great on paper, you collect all the data that you think you need, you start working on it, you either may not get the right sensitivity, the right specificity, or the right context of use, or it, like you said, maybe duplicates a job that's currently being done, and it's not the best use of resources, because AI systems are expensive. I mean, we heard from David earlier around the infrastructure investments and the data and so on. So not everything needs a hammer, you know, not everything needs AI. we've pulled many a plug from either traditional digital signal processing algorithms or AI-based algorithms if it doesn't meet the business muster, if it doesn't meet a business need or bubble up to a evidence that is believable. We've also reached as far out as created solutions, gone to the FDA, and FDA forced us to pull the plug, just because there was some considerations on data, considerations on use, considerations on safety that didn't meet the bar. Which is why, for everybody here, maybe my message is, if something is FDA cleared and CE marked and has gone through the rigor of 7-8 years development, clinical trials, regulatory evidence, that is not the same as the new version of GPT just came out last week that has been put out there. So we've pulled the plug on many a program that have been 7 years in development, 8 years in development, and some things we persist. Some of them you hear about, some of them you don't. But there is that rigor, that's the process doing what it's supposed to, which is the total product development life cycle, which is interrupted by clinical evidence and FDA clearance and CE marking if you're in other countries as part of that process. So.
This is my last question, and I'm going to give you all a chance to think about what your questions are, and we'll open it up. But in those situations where someone has spent a large part of their career, whether it's 2 years or 7 years, developing a model, and you have to pull it, not because, I mean, the FDA is one thing, but let's just say the business decided, not worth it. Mm-hmm. Can you give us an example of how you brought empathy into that conversation, or who does that? Just wondering the human side.
For products that are on the market or for R&D stuff?
For your R&D stuff.
We don't care about the R&D people. We just
Okay. Not much empathy.
Yeah.
No, I mean, there is, if you think of it as learning and building blocks, and you follow the Edison example, even a failed study or a failed R&D, it could have failed because it's ahead of its time, not because the technology wasn't sound or the solutions was ready. We have many a solution that do not survive just because the current reimbursement environment does not allow for these solutions to exist. We have a lot of solutions that could go on the market, but physicians are not ready to use it yet. My job with my team, so I'm the strategist, I'm an innovator. My goal is not to think about the next couple of years. I think about the next 10, 15, 20. So I'm mapping to things that the market's not really ready for now, but we believe that's where the puck is going, and we're skating in that direction just to make sure we're ready for it. So even the programs that get pulled, we document everything, we put it on the shelf, and we say this is worth revisiting at a later date. Some things morph into another program, so this may not be appropriate for this use case, but we believe we have something meaningful, let's adapt it to something else. And there are some things that are true dogs that we were like, you know what, we tested 10 ideas, 2 of them really, somebody should take them to the back and shoot them. So,
But you reframed it as learning. And
Absolutely.
That's a great takeaway.
Because the scientists and the engineers and the personnel that worked on this study, that's all like published, and we archive things internally, so we have this knowledge transfer. And you heard earlier from Lou around siphoning brain drain. I mean, we worry about what's old is new again, some things that have been created 10 years ago that the scientists are no longer there, and now we're recreating the wheel when we could have leveraged learning. That's creating a lot of opportunity for us to kind of maintain an internal library on all the things that were done, so we can find a different use for it as needed, as appropriate.
Thank you. Okay, I'm going to open it up to all of you. Yes? You'll get the mic in a moment.
Hi, this question is for Sarah. I'm wondering, where do the ideas come from, and do you have so many that you have a process for sorting through them?
Oh my gosh, thank you for this question, because I was going to say, can I follow up? Yeah, so this is perfect. We take our direction from the clinical practice. So our team is actually our CAO of Mayo Clinic Health System, Chris Hasse, has told us, you are the practice, right? You are going to be embedded in every single clinical practice governing body meeting, and you're just a member of the team. You're a fly on the wall, you're listening to the problems that are bubbling up, and you're spotting the opportunities in the moment. There's no shortage of demand for AI teams these days, right? So we can be very discerning and very selective in who we choose to work with. And it sounds really, really silly, but we use that DVF framework. That is our foundation. So we have a 30-minute discovery meeting. Truly, that's all it takes to talk through those different circles. And usually we end up pulling the plug or saying, okay, great idea, but you need to work on X before we can get started. And it's always viability. It's always, are there operations in place, or will there be, with the current resources that you have in the practice to support and sustain this solution long term? Do you have a workflow mapped out of what you're currently doing in practice and how you envision that evolving and this tool coming into play? If it's going to generate new patient demand for you, do you have capacity to see those new patients? Because we're definitely not going to churn up that demand if we can't take care of them. That's not doing right by those patients, right? So yeah, there's a lot we can do in terms of early detection, but we also need to make sure that we're doing right by our patients by ensuring we have operational capacity to care for them once we identify that there may be a problem. So yeah, we connect with the practice. The ideas come from them. A lot of it comes through email, not going to lie. And then we work with them as partners to vet the idea, and they appreciate it when we say, you know what, this is cool, but like you're not ready. Come back to us when you have this figured out. Or okay, it's a good idea, but it's not technically feasible for our team, and this is why. You don't have access to the data, right? Or it's not consistently reliable, or it's going to be too much of a financial lift to get it into Epic. Any number of things.
Thank you. Great question and great answer. Other questions?
So you kind of touched on governance with what you were just talking about, but I think about governance from a post-product standpoint, and you talked about, not only measuring right after you deploy, but then ongoing. So I'd just love to hear from both of you in terms of like that governance strategy, because I think about like BPAs in the EHR where it's like we just throw a ton of BPAs out and then you find out 3 years later that 97% of them are ignored, right? And so when you're making these AI models and you're like throwing all this out, how are you evaluating that you're effective, and then how are you innovating if they are ineffective?
Excellent.
So we have, as a regulated products, there's FDA required post-market surveillance and review. So we continuously track the performance of products that are in the field and look at their performance. So because they're locked, we don't expect them to drift, and we track that evolution. Once we believe we have an opportunity to retrain, redevelop, redeploy that solution, it's called an A/B testing method. You take the new data, you retrain, you then redeploy, and that's how we track. There's a formal, documented quality system managed process as part of the FDA's CFR process. So we do track post-market performance, post-market drift, and adoption. And usually the marketplace votes with their physician adoption. If there's something they did not like, that's input. So even if they ignore certain elements, there's a reason, so you don't have to double click on why, and we work that into our new iteration for new products to make sure we understand and deliver the value that's expected.
I thank you for this question, because I think that there's a lot to learn in this space. One of the things that we do at Mayo Clinic Health System when we're having that initial discovery conversation, if we decide to move forward, the very next step is my meeting with the stakeholder to do a remeasurement plan and a risk assessment before we get started. And it only takes another half an hour meeting and some asynchronous work offline, but it's what could go wrong, okay? Ethically, from a technical standpoint, from an adoption risk standpoint, business, clinical, thinking through all those domains, and we just have a conversation like what really could go wrong with this, right? And we're anticipating problems, and then we're saying, okay, well, what would we do if that happened? And we write it down. And who would be responsible? Like, who are you going to call, right? Write that down. It seems very basic. I mean, we learn all this in business school, right? But you actually have to do it in practice. And then it's really difficult to measure value post-implementation if you didn't know what you were setting out to do in the first place. So we write down our OKRs ahead of time. And again, we have an accountable person. We write down where the data is going to be coming from, what our baseline value is, what our target is. And that piece of it then becomes baked into the operations post-go live, because we're monitoring those metrics in every meeting that we have. And you need to have a de-implementation plan in place. That's another really critical component, is knowing where your kill switch is ahead of time. So while it's not exactly governance, I would say that's the way we approach our work. And depending on the nature of the solution, there's going to be different levels of oversight, right? So if we have an FDA-approved model deployed to practice, we're going to follow that regulatory process. And we have organizations within Mayo Clinic that we would partner with to ensure that we are compliant, right? But then if it's a simple clinical automation workflow, that's really going to be owned by our team in partnership with practice operations going forward. So it just kind of depends on the level of risk of the solution. But ultimately, I think it was Lou that was on stage here that said, I'm the one who's accountable, right? And we all are, right? It's not like I can say when the practice comes to me and says, this isn't working as expected. Oh, well, yeah, but the ball was in your court. We handed it off, right? Like everybody has skin in the game. It's teamwork. It's a constant evolution and collaboration. And really, ultimately, I'm accountable for the products that I'm developing in partnership with the practice. So it's just being a leader, right? Yeah.
I know that we have more questions in the room, but we don't have any more time. I hope that both of you are here for lunch in case anybody can catch up with you. So Rodolphe and Sarah, thank you so much for your comments, for answering some of the questions maybe I hadn't asked you in advance. So really appreciate that. And thank you for joining us. Thank you.